Good afternoon, all. A warm welcome from Sipla to this third edition of Surginar. The topic of today's discussion is surgical management of sleep apnea, which will be dealt none other than Dr. Vikas Agrawal, who needs no introduction. I welcome you, sir, to this program. We are fortunate to have these three editions of surgical management of various common ENT surgeries and as well as some difficult surgeries like sleep apnea because of one person, that is Dr. Dwipen Mukherjee. He is our scientific convener, guru, and because of his efforts, we are seeing these meetings happening. So, Dr. Mukherjee, welcome to this program. And after Dr. Vikas Agrawal's talk, today we will have a panel discussion and a question and answer from 50 centers across India. So today we are joined by one of the most senior members of from the ENT fraternity, Dr. Devinder Rai, Dr. Dipankar Datta, Dr. Seema Abhishek, and of course, Dr. Vik Agrawal will be the part of the panel. I welcome all of them to this meeting, and I have been tasked to introduce Dr. Mukherjee to all of you. I'm just sharing my slide. So Dr. Dwipen Mukherjee is an MBBS from Calcutta, MS ENT. He's professor, head of Department of ENT, KPC Medical College and Hospital, Kolkata. He's a visiting surgeon, Manipal Hospital, Kolkata. He's an ex-honorary secretary of AOI West Bengal, organizing secretary of AOICON 2017 and ISOCON 2019. He's a recipient of major KK Ghosh Award, and he has published around 15 articles in various national and international journals. Apart from that, he's a fantastic person and a wonderful moderator, speaker, and a panelist. Dr. Mukherjee, that's it from my side. Over to you, sir. A small request to all the regional moderators. So we have created a WhatsApp group for the questions. So whatever the question that you are getting from attending faculties from the physical centers, I request to put the question in the WhatsApp group, and those questions will try our best to answer all of your questions after the Dr. Vikas Agrawal's talk. That's it. Thank you.
Good afternoon, all. Thanks, Dr. Oshin, for your kind introduction. So this is the third edition or third session of Surginar. Previously, we had two Surginar sessions, one in the month of December 2021 with the topic of septoplasty, and again in the month of March 2022 with the topic of tympanoplasty. Now today we are having the third session related with OSA. So in this Surginar, the theme is to touch the basic, and by doing all those Surginar sessions, the main motto is that all these scientific discussions should be beneficial for the all ENT surgeons across the India in their day-to-day clinical practice. Today, we are having around 50 centers across India with 50 regional moderators. So I will request all the regional moderators to pass their questions or any queries from that center so that we can discuss all those questions at the time of panel discussion. Today we have power-packed faculties, those people who are doing in this field. First, the flow of event will be like this. Dr. Vikas Agrawal will deliver the session related with OSA and surgical steps for initial 45 minutes. And then Dr. Seema Abhishek, Dr. Dipankar Datta and Dr. Devinder Rai will join as panelists. At that time, we will discuss all those questions from different centers. I am from Kolkata center physically, but I will be connected with all the centers across India. So I will collect all those questions and will discuss after the deliberation of Dr. Vikas Agrawal. Now I will like to introduce all our faculties. First, our speaker, Dr. Vikas Agrawal. He is past president of the Indian Association of Surgeons for Sleep Apnea, chairman committee for the Sleep Disorders, Indian Academy of Otolaryngology and Head and Neck Surgery, director specialty ENT hospital, robotic sleep apnea surgeon, Asian Heart Institute, Mumbai, visiting ENT consultant, Seven Hills Hospital and BACS MG Hospital, Mumbai. He is pioneer and original researchers in this field. Released the first Indian guidelines for the sleep apnea surgery as president IASSA, formulated the first Indian informed consent form for sleep apnea surgery, performed the first robotic tongue-based surgery for OSA in India, first to webcast live robotic tongue-based surgery in the world for over 2000 ENT surgeons, discovered the role of salpingopharyngeal folds in the OSA and presented at the World Congress on Sleep Apnea in Rome in the year 2012, invented a new technique called SMELL 3-cut technique, a pioneer in DICE and coblation surgery in India. Welcome, Dr. Vikas Agrawal. Next, we will have 3 panelists. Dr. Simab Sheikh from Pune. He is the head of the Department of ENT in the Inamdar Hospital, Pune, founder national president of IASSA, consultant ENT surgeon, KEM Hospital, and Shayadri Group of Hospital, Pune. Next, we will have Dr. Devender Rai. He is the senior consultant and vice chairman, Sir Gangaram Hospital. He specializes in endoscopic image-guided and nasal and sinus surgery, voice disorder, snoring disorder, coblation surgery, robotic surgery for sleep apnea, and balloon sinoplasty. And Dr. Dipankar Datta from Kolkata. He is the consultant ENT and sleep apnea surgeon in Bellevue Clinic and AMRI Hospital, Kolkata. Member of governing body IASSA, member of International Surgical Sleep Society, founder of the Society for Education and Research on Snoring and Sleep Apnea, and European Board Certified Fellow in Sleep Apnea Surgery, Forlì, Italy. So we have all those doyen in this field. So without wasting any time, I will request Dr. Vikas Agrawal to deliver his lecture.
Thank you, Dr. Dipayan, for the nice words and the introduction. At the outset, my sincere thanks to the whole team of Cipla Respiratory and Dr. Dipayan for inviting me here to present my work on obstructive sleep apnea surgery. In the next 45 minutes, say around 2:15 to 3 o'clock, I'll try to get the basics of surgery into the minds of all the delegates present at the 50 centers which are across the country. I'll share my screen. Are you able to see the presentation?
Yes, you can proceed.
Okay. So as Dr. Dipayan asked me to touch the basics of sleep apnea surgery so that the concept of this surgery goes into the minds of the young surgeons. So I'll be dealing with the mechanism of obstructive sleep apnea and the principles of surgical management. So I bring you greetings from Mumbai. Snoring is a very, very common problem. Every house has a snorer. What is obstructive sleep apnea? It's only an extension of snoring. So many people who are not fresh in the morning when they get up. So in spite of sleeping for 7 to 8 hours, still they are not fresh in the morning. What is the cause? So what is happening inside? When the throat muscles relax, the person cannot breathe, and that's called obstructive apnea. When it lasts for more than 10 seconds, it's labeled as an apnea, and then the patient wakes up and he starts breathing again. This cycle keeps on repeating itself, and if you see actually inside which part of the anatomy, it is mostly the soft palate, which can also be associated with the base of the tongue. And at this point, if the brain does not wake the patient, that's the end of life. So it's a serious condition which keeps on repeating itself throughout the night. But the problem is that in spite of the risks associated, which are like stroke, diabetes, heart disease, more than 3 times the risk of cardiovascular health is affected in this condition. And more important than that, more than 6 times the risk of traffic accidents. That this we never tend to remember. The person is sleepy on the wheels and he meets an accident. And this is the leading cause of traffic accidents. So understanding and treating sleep apnea is not only important for the person's life, it's also important for the other people around him, their life. Unfortunately, 80% of the patients of obstructive sleep apnea are undiagnosed when the situation is as common as 1/5 of women and 1/3 of men. And it is an estimate that there are more than 100 million patients worldwide. So this problem is still underdiagnosed and less understood. So what is the problem all about? The problem is all about the balance of supply and demand. So the demand is caused by obesity, the body weight. When the obesity is more, then the demand is more. And the airway size, if the airway size is smaller or the collapsibility is more, then the supply becomes less. So when the demand is more and the supply is less, then only sleep apnea can happen. It cannot happen the other way around. So if a person is obese, but his airway is pretty large and not collapsible, he'll have no sleep apnea. But on the other hand, a thin person who does not have obesity can still have sleep apnea because his airway can still be small. So though obesity causes more oxygen demand, but as I said earlier, if the airway is not narrow, he still will not have sleep apnea. So by reducing obesity or by performing obesity surgery, we try to reduce the demand, and by performing airway surgery, we try to increase the supply. So this is the basic balance that we try to maintain. And this is what, if we understand that it's not necessary that a thin patient cannot have obstructive sleep apnea, and it's not necessary that an obese patient will always have obstructive sleep apnea. This is the fine balance. And these are the two ways by which we can either reduce the demand or increase the supply. Now, there's a very big set of patients, very, very big actually, who is non-obese. And if you do the sleep study is also normal. So they're not having obstructive sleep apnea, but they are still having headaches, depression, forgetfulness, poor concentration, lack of energy, tiredness, mood swings. What is this subset of patients? A very, very big number of patients who are actually visiting doctors' clinics, being treated for blood pressure, being treated for anxiety, being given antidepressants, are actually cases of upper airway resistance syndrome, which is between simple snoring and obstructive sleep apnea. So what is upper airway resistance syndrome? When a person's sleep study is normal, but he still has all these symptoms, which I enumerated earlier, then this patient is possibly a case of upper airway resistance syndrome. And how common is this? You can actually imagine almost 50% of the population has some kind of deviated septum or turbinate hypertrophy. 25% of the population has an allergy. So if you make a combination of this, we are talking of between half to 2/3 of the patients who have this varying grades of upper airway resistance. This term upper airway resistance was coined by the same person who coined the term obstructive sleep apnea, that is Professor Christian Guilleminault. I had the privilege of meeting him 3 or 4 times. And this was, I think, 2013-14. And this is what he drew the attention to: pediatric obstructive sleep apnea, adults with normal sleep study. And this is the first thing that all our ENT colleagues should remember, because this is much, much more commoner and easy to treat than the typical upper airway resistance. So let me give you an example. What is upper airway resistance and what is obstructive sleep apnea? So if you hit a young person in his 20s, he will possibly hit back, or he will not fall. He might feel disturbed. So he'll have pain, he will feel disturbed. He might hit you back, or he'll not fall for sure. This is upper airway resistance, that the upper airway is narrow, that is causing resistance, but the person's airway is not collapsing. That is upper airway resistance. He is symptomatic, but it's not collapsing. When you hit the same person in his 40s or 50s, he will collapse for a time, but he'll get up because he still have some energy. So this is mild or mild to moderate obstructive sleep apnea. The person will collapse, but will get up in time. So that is mild or moderate obstructive sleep apnea. But if you hit the same person in his 70s, he will possibly not be able to get up because he does not have energy. So this is severe obstructive sleep apnea. This is just a corollary. So you can understand that if you catch the person in his young life and treat him at that point of time, he'll possibly not go into moderate or severe obstructive sleep apnea. So it's very important to treat the person, catch the person and treat him when he's only having upper airway resistance. And where is the resistance? Where is the upper airway? Upper airway is in the nose, palate, or tongue region. So suppose if there's an obstruction in the air passage, like this, which is causing a traffic jam, if there's an obstruction on the road, which is causing a traffic jam, this is not the right way that you get out of your car, sit on a bike and try to negotiate the traffic. Nor this is the right way that you try to push your car between two trucks. This is what actually CPAP is trying to do. If the airway is narrow, it is trying to squeeze some air through it, which is not natural. And therefore, more than 70% of the patients do not accept it over a long period of time. Compliance rate is almost 30% or even less. The natural way of treating is only to remove the obstruction so that the highway is clear. So if we have to remove the obstruction and treat it naturally, we have to understand what is static obstruction and what is dynamic obstruction. Obviously, it's a no-brainer. If somebody's nose is blocked, how will you put a CPAP on his nose? He will not accept it. He'll not, if the nose is partially blocked, the airway pressure will be so high that he'll not be able to accept it. Whereas if the problem is in the pharynx, say soft palate or tongue, then it's a possibility that you can put the CPAP which can push some air inside. So static obstructions, generally nose and nasopharynx, you have to clear irrespective of the BMI, AHI of the patient. That is first and foremost single important message to my young colleagues, that you have to remove the static obstruction, that is the nose and the nasopharynx, and you are very well equipped to perform these surgeries already. As I said, if the nose is blocked, even CPAP will not work. Other thing is that when the nose is blocked, mouth remains open. When the mouth remains open, then the mandible goes down. When the mandible goes down, the hyoid also goes down, and the base of the tongue is attached on the hyoid bone. So ultimately, if the nose remains open, then the base tongue also collapses. That's a double problem. So you do a CT scan in every single patient of obstructive sleep apnea. You'll figure out the thickness of the bone, deviation of the septum, thickness of soft tissue of the inferior turbinate. You'll also look at the ethmoids, because many times ethmoiditis is obviously missed on the X-rays. So you have to do the CT scan to understand what is happening. The configuration of the turbinates, especially the posterior part of the inferior turbinate. Adenoids, very commonly you see adenoids in adults, very, very common. So do not miss them. And then perform whatever surgery. Now, septoplasty, you all know how to do it. I'm only trying to suggest here that if you look at this, this is the navigation showing you the septum. What you think is very high septum is actually below the frontal bone. It's not below the cribriform plate. So the high septal deviation is very, very commonly left out. This is the commonest I have found in my revision septoplasty that I have performed in the last 20 years. That high part of the septal deviation is not removed, fairing skull base. Mind it, the thick part of the bone is not below the, you see here, this was the thick part even after removal. It is below the frontal sinus, it's not below the cribriform plate. So please remove this part of the high septal deviation. Unfortunately, it is less taught. It is our fault. We should have taught you before. But please take care of this part. Look at your CT scans. You'll know that the thick bone is below the frontal and not below the cribriform. Second, if the middle turbinate is really very large and boggy, in a case of allergic polyposis, rhinitis, whatever, sometimes you have to remove the middle turbinate. Do not think middle turbinate can never be removed. I'm not saying that you remove all the middle turbinates like this from this stump. I'm not saying so. But if really required, you might have to do it. And what we have actually tried to found a new way. This is the way forward. This is our evaluation. We are in process of evaluating sonopet for middle and the inferior turbinates. So if the middle turbinate is so large like this, sonopet is a technique by which you can selectively melt the bones without touching the soft tissue. So in coblation, you take care of the soft tissue. In sonopet, it's a very highly 25,000 hertz is the frequency on which it removes the bone, but it leaves the soft tissue. So you can actually get a lot of airway here. And you can use the same thing on the inferior turbinate, and you see the mucosa is completely preserved. Because the airway is here, the high part of the deviated septum and the middle turbinate. This is the area where the maximum concentration of air goes. And unless you take care of that part, your nasal surgery is bound to fail in terms of the blockage. Coming to the inferior turbinate, again, inferior turbinate you can divide into 6 parts: anterior 1/3, middle 1/3, posterior 1/3, and superior inferior, superior inferior, superior inferior. Now, if you see the anterior 1/3 is mostly sinusoidal. This you can see it in the red part. This is erectile. The lower part and the posterior part is mostly polypoidal, which contains more of mucus glands. So no medicine actually works on that. Your Otrivin or oxymetazoline will not work on that. Your spray will not work on that. So you have to actually take care of that part. And if you only remove the lower part of the inferior turbinate and leave the upper part, you will never have a problem of empty nose syndrome. So now you see, this is the sinusoidal part. Anterior 1/3, upper part is sinusoidal. It's full of blood vessels. The lower part is polypoidal, which is more of mucus glands. The whole lower part and the posterior end is polypoidal, more of polypoidal. And the middle 1/3 is mostly bony. So if you outfracture the middle 1/3, see how much space you create. And the space is right in the area that the air has to travel along the middle turbinate. That's the area that the air has to actually travel. So simple outfracture of the middle turbinate creates a lot of space. And then the posterior end, as I said, is polypoidal. So you can either simply debride it and touch it with a suction cautery. Matter is over for life. If you debride and cauterize, and you can actually go ahead and debride the whole of the lower part of the inferior turbinate. I'm just giving a very, very simple technique because almost everybody has got a micro debrider in the theater. So you can simply remove the lower part of the inferior turbinate and touch it with the suction cautery, and you'll have a very, very good result for a very long time. If you want to remove, you can remove a small bit of bone from the inferior part as well. Or you can use coblation. If you have coblation, you can use coblation for the polypoidal part. If you do not have, a simple microdebrider is good enough. You can also use coblation for the anterior 1/3 of the turbinate, which is sinusoidal. You can use different techniques like, cautery, you can use radio frequency. And this is, first time we have used the sonopet on the inferior turbinate bone. Obviously, this is in the trial stage, but you can see that it can take away the bone without damaging the mucosa. So you can selectively remove the bone, you can selectively remove the mucosa using coblation or microdebrider, and you can use the sonopet to remove the bone. So these are the new things that will certainly come in times to come. You have to just keep a watch on what is going to come. And when are you performing endoscopic sinus surgery for polyposis or even ethmoiditis, you have to go right till the skull base. You see the difference between the skull base as well as the septum. Using navigation is a very great tool because very often we keep on.
And that's the frontal recess. You can see that's the frontal recess. With a 0, I've gone inside. Now, just behind the frontal recess, I have already removed some air cells here. But you see, unless you remove all these air cells, you will always get a recurrence. And the anterior ethmoidal artery is going to be one cell behind, so it is going to be somewhere here inside. So unless you know where is the anterior ethmoidal artery and where is the skull base, you are unlikely to
basically
right till the skull base.
Do a complete job and remove each and every air cell in ethmoiditis.
So this
or
area which is between the frontal artery, between the frontal and the anterior ethmoidal artery in polyposis.
And you have to get something like this. You can see the frontal and the sphenoid with a 0 degree. Spray is only going to go straight. It cannot go and turn. So surgery with a 0 degree, view with a 0 degree. Now your spray will completely take care, because if there are a lot of secretions still happening, your sleep apnea problem is going to continue, because the postnasal drip will increase the viscosity of the secretions, the nasopharynx, and that will lead to obstructive sleep apnea. So this is the importance of understanding all these things. When you are performing adenoidectomy, obviously, coblation is a very good tool, and you have to go till the boundaries. If you do not go till the boundaries, the airway will open, but still the cells will keep on secreting. The adenoidal, the lymphoid cells will keep on secreting. So these are the boundaries you can see in my paper of 2016. You have to go till the boundaries, and you can see the buccopharyngeal fascia, the white thing at the back. You have to remove all the lymphoid tissues, especially in obstructive sleep apnea cases, whether it is adult or pediatric. and go till the boundaries. Now coming to dynamic obstruction. So this was about static obstruction that each and every ENT surgeon can deal, right? This does not require any training on obstructive sleep apnea. Coming to dynamic obstruction. So dynamic obstruction is in the pharynx, mostly in the 75 to 80%. It is only in the behind the soft palate or retropalatal, and around 20-25% have multi-level, which is nose, palate, and hypopharynx all. So if we understand the soft palate a little better, it will help us to decide and deal it in the perfect way. So how is the dynamic obstruction assessed? Since the time is limited, I cannot go into all the details. We do it by drug-induced sleep endoscopy. How it is done with BIS monitoring, we put a scope into the patient's nose and go into the pharynx and see which part of it is obstructing. And then look at the structures, their configuration. This is drug-induced sleep endoscopy. Now, looking into the drug-induced sleep endoscopy for last 12 years, we have now understood what is the movement of different structures of the pharynx. So tonsils move superiorly, medially, as well as posteriorly. So when we look from this angle, we can only see two frames, two axes. But if we look from this frame, the tonsils also move posteriorly. So we have also understood that it is not important only to look at the belly of the tonsil, which is the current classification, but we have to also look at the body of the tonsil. The current classification only looks at the belly, only from one direction. But if the shoulder of the tonsil and the head of the tonsil is big, then that's also going to create obstructive sleep apnea, because this is how it is going to push at the back. And if you remove the tonsils, the retropalatal space improves like this. So the width of the tonsil, not only the tummy, the width of the tonsil, the height of the tonsil, everything is important. We have understood the role of the muscles. This is the tensor palati, which obviously does not participate in obstructive sleep apnea. The levator palati, which we all are scared, which is again more cranial to the area where the sleep apnea is happening. So the swallowing is happening more cranially than the sleep apnea. And this is the beauty that you can actually operate on that area. Levator palati is much, much more cranial. This is the anterior pillar of the palatoglossus, which obviously does not participate in obstructive sleep apnea. It is only the muscle which is palatopharyngeus, which is actually the problem. And this is what we have to deal with. And you would agree that all the palatal surgeries are based on palatopharyngeal muscle. So if you respect this Lakshman Rekha, if you do not go beyond the levator and the tensor palati, then your sleep apnea surgery, palatal surgery, is going to be successful and free of complications. So based on this, how do we decide how much we can resect and what can be done? So this field is still growing. For the last 30-35 years, we are still understanding what is happening. So this is my technique. Basically, the idea is what? For any snoring surgery, the idea is what? If we look at the sleep apnea snoring video from above, the area which was collapsing and the area which is for swallowing, the blue line is where the levator palati is working. And if you look at the area which is collapsing during obstructive sleep apnea, is much lower. And if you go back and see what was the structure, this was the superior pole of the tonsil coming closer. Can you see that? The palate is moving behind, the base of the uvula is moving behind. It's not the tip of the uvula. Base of the uvula is moving behind, right? The tip of the uvula is below, and the superior pole of the tonsil is coming closer. The inferior pole of the tonsil is not coming closer. So once we understand this, then we know that we do not have to deal with the base of the inferior pole of the tonsil. And where is the blood supply of the tonsil coming from? Inferior pole. That gives us a very, very good security that if we do not deal with the lower pole, bleeding is not a problem. We only have to deal with the superior pole. And superior pole is covered by what? Palatopharyngeus, right? So it is the palatopharyngeus coming closer. So only removing tonsil will not work. We have to do something to the palatopharyngeus. And we have to do something to the base of the uvula. Doing something to the tip of the uvula is not going to work. So these are the simple things, common sense things that we understand by this. Now, if we make a diagram of what we saw. So this is anterior, this is posterior, uvula, tonsils, palatoglossus, palatopharyngeus, and lateral pharyngeal wall. Now, we can see that behind the uvula and the tonsils, the airway is behind that. Now, if we try to remove the tonsil, obviously, therefore, tonsillectomy is sine qua non of any sleep apnea surgery. We remove the tonsils. Now, what happens? Once we remove the tonsil and take the palatopharyngeus forward, see how much space is created. So this is why tonsillectomy is required. And if you pull the palatopharyngeus forward laterally, you create a lot of space. So now, fortunately, God has given a very important structure called pterygomandibular raphe in our bodies, which is anterior and lateral to the soft palate. Always. The anterior and lateral could be varying depending on the width of the palate and depending on the length of the palate, but it is always anterior and lateral. And this is a fixed structure between the pterygoid tubercle of the maxilla and the mandible. So if we suspend the soft palate on this structure, which is anterior and lateral to the soft palate, then obviously soft palate cannot collapse. So this is a suspension bridge created hanging on the pterygomandibular raphe of one side, going across the midline to the other side, other pterygomandibular raphe. So once we do this, the soft palate cannot fall posteriorly, correct? And we saw that to create snoring and sleep apnea, the soft palate had to move posteriorly. If it does not touch the posterior pharyngeal wall, how will the snoring happen? Now, if we also suspend the palatopharyngeus laterally from the same pterygomandibular raphe, then obviously now the posterior pillar or the this fold, posterior pillar cannot fall posteriorly, it cannot fall medially. So if we are able to do both, then whether the collapse is AP, lateral, circular, everything will be taken care of. And this is the simple philosophy. Now, as I said earlier,
So now, as I reach towards the lower pole, I have to make sure that there is no bleeding in the post-operative period. So I coagulate along the length of the proposed tonsillar artery and then dissect at the medial part of it.
So the tonsillar artery does not come exactly at the inferior pole. It comes a little above the inferior pole. And the tonsillar artery is a big artery. So if you cut it at one place and do not tie it, or even if you tie it, there's a chance it will open again. Tonsillectomy, the most important complication is a bleeding. On table afterwards, 7 days, 10 days, it can happen. So if you coagulate along the length of the tonsillar artery and then cut at the medial aspect, then the chances of bleeding will be absolutely minimum. Last 7 years, I'm doing this and my touch wood rebleeds have gone down to almost zero. I have not seen it in the last 7 years. So you can do this if it is an infected tonsil, or
here I will go intracapsular. So I will not go into the muscles, I'll go into the tonsils very, very close. You can see this is intracapsular. Then coagulate this part and then gradually ablate the extra tonsil which was there. By doing so, I will make sure that the tonsillar artery is not exposed, because if the tonsil is large, the tonsillar artery is also going to be large, and then the chances of a post-operative bleeding is a little more. So in this area, I have preserved a very small part of the lymphoid tissue. That makes the surgery safe in terms of bleeding post-operatively.
now this patient is actually BMI 35, AHI 110.
Now,
right? So he's absolutely a disastrous patient if he comes with a post-operative bleed, correct? So
if I push my finger,
so that part was to make sure that it does not bleed post-operatively. So the lower part, I have coagulated, left a little bit of tissue at the lower pole and coagulated it. So the tonsillar artery is not exposed and it's completely fibrosed. Now, how much of this soft tissue uvula can be cut? Or the soft palate can be actually cut. Nowadays, the world is going towards uvula preservation. They're condemning that if you remove the uvula, then you have done a very, very grave mistake. But a patient of BMI 35, AHI 110, not tolerating CPAP, what do? If you leave behind a soft palate which is so long, you're not going to do him any good, right? So how much of the soft palate can be actually sacrificed? So you'll see it very easily.
Along the soft palate. Now, if this is the soft palate, I push my finger. See, it's going and touching here. It's here. It's much above the line joining the anterior pillar to anterior pillar. Can you see that? So now this soft palate is quite long. If I preserve this soft palate, whatever I do, it will still keep on collapsing. So a suspension bridge pharyngoplasty will definitely help to prevent this collapse. But this soft palate is pretty long and his body mass index is 35, apnea hypopnea index is 106. So I definitely want to remove the extra length of the soft palate. Now this is the required length. You can see my wand going and touching at the back. So anterior pillar to anterior pillar is a very safe margin. And even if I remove a little higher in this case, so I'll remove it from here, little higher, just above the line joining anterior pillar to anterior pillar.
Anterior pillar to anterior pillar
So here,
is the base of the.
now I'll be still saving a lot of soft palate required for swallowing and phonation. And you see, this is still the anterior pillar. This was the curve. So this is the anterior pillar to anterior pillar margin. And we have to make sure that we do not go high into the palatal aponeurosis. So we'll make sure that levator palati is not damaged. We might hug the palatal aponeurosis here, but will not go very high into the palatal aponeurosis. So this is the palatal aponeurosis. Will not go very high into the palatal aponeurosis. You can see this is the musculus uvuli already twitching. This is the palatal aponeurosis. So we'll just hug the palatal aponeurosis, but will not go high into it. And this is the musculus uvuli. You can see the musculus uvuli very well. So this is the musculus uvuli, and here this is the posterior pillar. These are the fibers of the posterior pillar or the palatopharyngeus muscle. So I am cutting mostly into the fibers of the musculus uvuli. These are the fibers, the vertical fibers of musculus uvuli. The horizontal fibers of palatal aponeurosis I am not really cutting, but I am pulling out the musculus uvuli as much as possible and then cutting through them. Okay, so that's the musculus uvuli already dissected. And as we go on this side, these are the fibers of the palatopharyngeus. So we'll have to cut into the oblique fibers of the palatopharyngeus. But before that, let me preserve the mucosa on the pharyngeal aspect of the soft palate as much as possible. So I'm dissecting between the musculus uvuli and the mucosa and trying to preserve as much mucosa on the pharyngeal aspect as possible so that the healing is better. Now this is the mucosa. And now I'll cut through the fibers of the palatopharyngeus. You can see huge palatopharyngeus muscle here. These are the oblique fibers of the palatopharyngeus. I will only cut through the palatopharyngeus muscle. I'll not cut through the mucosa, but I'll cut through the whole oblique head of the palatopharyngeus. Because this area is the bottleneck area in obstructive sleep apnea. So I will remove as much as muscles as possible from here, but I'll try to preserve the mucosa. And now let me remove this uvula. So I'll make a sharp cut here on the left hand side. I'll come to the left side next. Once I'm done with the right, then I'll come to the left hand side. I'll do all the dissection of the left hand side later. So this is the mucosa which is saved. mucosa which is saved, and this is the palatopharyngeus which I'm going to rotate laterally like this. So I'll make a cut here. So I'm going to make a cut on the palatopharyngeus muscle. And now you can see this part of the soft palate along with the uvula is out. Now as we come to the palatopharyngeus muscle here, see, this is the palatopharyngeus muscle which was forming the anterior wall of the pharynx. Now I'll transpose it and make it the lateral wall of the pharynx. So you see I have saved the mucosa here. Little bit of muscle dissection is still pending. So let me perform the muscle dissection first. That's the bottleneck area. All of the oblique fibers are dissected. The vertical fibers are coagulated. Now I'll make a sharp cut here and transpose the palatopharyngeus laterally. So there's no loss of mucosa, it's only a sharp cut, and you can see that the whole palatopharyngeus will be transposed laterally. So we know that the superior pole of the tonsil and the base of the uvula is the bottleneck area in obstructive sleep apnea. So we have opened that area which was here completely, and now we will take a vicryl suture and suture this palatopharyngeus laterally so as to transpose the whole palatopharyngeus laterally. Now where is the pterygomandibular raphe? Pterygomandibular raphe is here. This is the mandible, this is the pterygoid tubercle. Between the pterygoid tubercle and the mandible you get the pterygomandibular raphe. So for demonstration now, see, this is the pterygomandibular raphe here. Okay, this is the pterygomandibular raphe. It's a pretty tough structure. So you have to be lateral to it. Go into the supratonsillar area. This is the bottleneck area. So you have to be in the bottleneck area. Go a little below the whole bulk of the palatopharyngeus muscle. You can see I'm taking the whole bulk of the palatopharyngeus. Taken care of. And then we will come. See that? And gently pull it. There is no need to put any extra pressure because then it will cut. So now we will go for the suspension bridge pharyngoplasty to make sure that the anterior pillar, the anterior posterior collapse does not happen. So as you can see, we have already taken this palatopharyngeus laterally. We'll again start lateral to the pterygomandibular raphe and we'll come across the midline with a barbed suture. So the barbed suture that I'm using is a V-lock 3O non-absorbable suture, so that it will remain in place and it will act like a suspension bridge. So give me the, yeah. So that is the pterygomandibular raphe. So I'll start lateral to the pterygomandibular raphe, go deep into the soft palate, come at the superior pole of the tonsil, of the right tonsil which was here earlier. Now the loop has to be completely buried. So very gently I'll pull the loop inside so that it's not seen outside, because it's a non-absorbable suture. So the loop has to be completely buried. As you can see here, the loop is completely buried and it's lateral to the pterygomandibular raphe. Now I'll go in from the same place deep into the soft palate and come across the midline. So from the same place here, deep into the soft palate, taking the whole bulk of the soft palate and come across the midline. You can see here. So now this, when pulled, you can see it will not let the soft palate collapse posteriorly. But when the person is swallowing, this can definitely move upstairs. That's the whole logic. So now we have performed tonsillectomy on the left hand side. And as you can see, this is the palatopharyngeus muscle of the left hand side. And these are the oblique fibers. This is forming the anterior wall of the pharynx as of now. So we'll cut through the oblique fibers of the palatopharyngeus completely. And we'll transpose them laterally to form the lateral wall of the pharynx. So anterior, take a good amount of thickness
It laterally in
went
the same way.
till the superior pole of the tonsil on the left hand side. And from there I'll get into the pterygomandibular raphe. This will make sure that the antero-posterior collapse of the soft palate does not happen at all. And this is what takes away the snoring almost completely. So I'm again going lateral to the raphe, as you can see, came out lateral to the raphe. So this is the pterygomandibular raphe here. I'm lateral to it. And then to reinforce, I will come back from the same side, from the left hand side, come back onto the right hand side. So this is a two-fold reinforcement. So now I again enter from the same point, come at the superior pole of the tonsil, take it out, and then now see, this is engaging the pterygomandibular raphe. And now because it's a barbed suture, so you do not have to take knots. You can already see that the soft palate is quite tense at the lower border. This cannot collapse down anymore. I will just take one more reinforcing turn. So I'll come back to the right side across the midline. And for the last part, I'll go till the right pterygomandibular raphe and cut it off. Come out here. And then I'll possibly go once more and reach the pterygomandibular raphe on the right hand side. So this is the final thing. Again, you enter from the same place and make sure that you are lateral to the pterygomandibular raphe. That is the most important thing, and you have to be a little deep. You cannot be very close to the mucosa. It's a non-absorbable suture. So, and here we can either just cut it off or you can take a U-turn. Either ways. So this has locked very well, so I'm just cutting it off here, and that's about it. So this is the barbed suspension pharyngoplasty. Now I'll show you the end result. Now see, this soft palate cannot fall because from one pterygomandibular raphe to the other there's a suspension bridge. So this part cannot go back. But when you swallow here and with the action of the levator palati, this can always move. And I am told that this is our 62nd case, right? This is our 62nd.
So basically this acts as a suspension bridge. Now this is the thing which is possibly the future for simple snoring, because in simple snoring, most of the patients have a AP collapse. They do not have a lateral collapse. So mostly AP collapse, and this possibly is the future. We are still in process of evaluating. If that comes, if you can reliably treat simple snoring, then you imagine what is the number of patients which are lined up, right? It's a lifestyle problem. And second thing is that you cannot do this cutting business with cautery or radio frequency. Plasma or coblation is the must, because you cannot give fibrosis at the cut edge of the soft palate, because that will lead to nasopharyngeal stenosis, which will be a disaster. So these 2 points are very, very important. So this bridge can move sideways during swallowing or phonation, but it will not collapse. So this is the whole philosophy. This is how the end result looks like. You can see the patient is able to swallow very well. There's no problem during swallowing. The bridge actually moves up.
Switch on the CPAP.
Now, last 5 minutes, coming to how CPAP works. This is how actually CPAP works.
CPAP air. Switching the
CPAP actually creates the soft palate.
keeping the palate open.
Now we switch it off.
Switch off the CPAP.
Again, patient is going to apnea. This is how actually CPAP works. But it works on the soft palate because that's a tube. Soft palate can open. Tongue cannot be lifted. Tongue is a very big muscle. So definitely patients who have a tongue-based issue have to be operated upon. CPAP does not work on them. But obviously, tongue-based surgery is a whole together different area, and my time does not permit. So basically, lymphoid tissue have an altogether different, way of dealing. When you go inside the muscle, that's a totally different way of doing. But basically, tongue-based surgery can be done with coblation, but can be done with robot. Coblation does a very, very good job, as does the robot. Obviously, robot is more costly. So when you are performing tongue-based surgery with coblation, you have to start from the foramen cecum. Gradually, layer by layer, you have to remove. With the robot, you actually go inside and take a bunch of tissues out. And when you do the surgery, the end result is you have to reach the median glossoepiglottic ligament. So that whole base of the tongue is reduced and the epiglottis is stuck to it. Now, tongue-based surgery should not be, I'm not dealing in detail because the younger colleagues are not supposed to jump on it because it's a pretty dangerous surgery. Things can go wrong, which can be life-threatening. Now, glossoepiglotopexy, in the next 2 minutes, I'll deal with that. I call it a minimum surgery, maximum results because it's very common if the person is having epiglottic collapse. CPAP does not work because CPAP actually pushes like a lid. In that case, you can do a very, very good job. But here the point is that you do not go laterally. Can you see this vessel? This blood vessel comes in the lateral glossoepiglottic fold. So do not go lateral. That is the one take home. When you are performing glossoepiglotopexy, you can do it with plasma. You can do it with radio frequency. You can do it even with cautery, with a bipolar cautery. You are only supposed to remain in the medial part. Median glossoepiglottic ligament has to be coagulated. And you have to just, denude the adjacent areas of the epiglottis as well as the tongue base. You're not supposed to reduce the tongue base. You're only supposed to create a raw area. So I'm just showing, this is the median glossoepiglottic ligament, and you can coagulate the median glossoepiglottic ligament, and immediately you can see the ligament getting lifted up. And gradually, I'm just fasting forward because my time is I have just 1.5 minutes more. So you create a raw area on the adjacent surfaces of the tongue and the epiglottis. And this raw area will gradually pull up the epiglottis. And it's a hardly 6-7 minute surgery, which will give you an excellent result. The patient who was not tolerating the CPAP can also now, get rid of the sleep apnea problem. This is generally seen in people with less BMI, 21, 22 BMI, and less AHI, 10, 8, but CPAP is not effective and they cannot sleep. So this is a very, very good surgery. So my time is up. I thank you for your, participation. And I think I give it back to Dr. Dipayan for the panel.
Thanks, Dr. Vikas, for your excellent deliberation. Now, I am already flooded with questions. So now I will request Dr. Simav Sheikh, Dr. Dipankar Dotto, and Dr. Devendra Rai to please join to discuss all those questions along with Dr. Vikas Agrawal. So without wasting any time, So I can start taking questions. First, I will ask this question to Dr. Dipankar Datta. This question is from Dr. Haryendra. How can you assess the
The weapon, your audio is lost.
Am I audible now?
Perfect.
Yeah. So the question for Dr. Dipankar Datta, how can we clinically assess the VSA patients by taking history and clinical examination by Epworth and stop bang? This is the question from Dr. Haryendra. Is Dr. Dipankar Datta is audible?
Am I audible?
Yes, we can hear you, Dipankar.
Okay. So, very good question. But the fundamental take-home message, at the outset, I would like to tell that Epworth sleepiness scale is basically a scale for sleepiness. How much I am sleepy. That is the index of the drowsiness, whether I am falling asleep, sitting in such kind of meeting, post-lunch session, whether I am sleepy during driving, or different scale questions are there, 7 questions are there. But stop bang, there are 8 questions actually. So where S stands for snoring, whether I snore or not. T stands for tiredness. Epworthness is basically this T. Understand? Stop bang is basically STOPBANG, where S stands for snoring, T stands for tiredness, O stands for observed apnea, whether I am choking during sleep, P stands for pressure, that means whether I am hypertensive or not. B stands for BMI, my body mass index is more than 35 or not. A stands for age, whether I am aged 50 years or more. N stands for neck circumference, means my collar size is more than 40 centimeter or not. And G stands for gender, whether I am male or female. If answer to any one question is yes, we score as 1. If answer to any question is no, we score as 0. So the total cumulative score of 8, there are 3 scales. If it is less than 3, that means very less chance of sleep apnea. Between 3 to 5 means total out of 8. If the score comes as between 3 to 5, means I have a moderate chance of sleep apnea, and more than 5 means severe chance of sleep apnea. That means even before doing any sleep test from the chamber, just by asking simple question and basic measurement and the clinical evaluation, I am a bit of mental map. Yes, probably I am dealing with a sleep apnea patient. And Epworth sleepiness score is nothing but that second question, that is T, how much I am sleeping. So stop bang is more usually basically used by us when we are dealing with a patient of suspected OSA.
So that means both are important. Basically, Epworth is trying to evaluate the T, and for clinical evaluation, both these things are important. Now, next question I will like to ask to Dr. Simaf Sheikh. This is also from Dr. Haryendra. Principle of choice of surgery.
Okay, so Dharpan, that's like a very, very major, full, broad blanket question. I really don't know how I can answer that question, because principles of surgery basically will depend on where the level of obstruction is, what we have found out. So if you're talking to me about principles of surgery, it is to open up the airway as much as we possibly can. The principles of surgery basically remain whether we are dealing with either a dynamic obstruction or a static obstruction. Those are the things that decide, and the levels of obstruction decide whether we should be dealing with them all at once, or are we going to do 2 at a time, or, different levels at different stages. So, it's too broad a question, I think, to really answer. That's the best way that I can put it across to you, sir.
That means the principle is where is the actual level of obstruction, and whether it's a dynamic obstruction or static obstruction. Now, next question is to Dr. Devendra Rai sir. This is from Dr. Venkatesh BK. is there any specific airway anesthetic issues related with OSA patients undergoing routine ENT surgeries? This is for Dr. Devendra Rai, sir.
As far as the anesthetic problems are there, we definitely get a pre-anesthesia checkup done. And if these people are having a sleep apnea, the anesthetist asks them to get the BiPAP or the CPAP with them. Second is we do warn them of a possibility of an ICU admission or even a prolonged intubation. Muscle relaxants are to be used with care, but I don't think there's anything else which I can imagine. Of course, we get all the cardiology checkup also done for that.
Okay, now this is for Dr. Vikas. Preoperative preparation and postoperative management of patients after OSA surgeries. That means before and after OSA surgeries.
So this is a very, very important question, because unless you decide what is the problem, how do you prepare for surgery? So when deciding to do a surgery, preoperative preparation, we typically are, only thinking in terms of AHI and BMI. Like this patient which I showed, 35 BMI, pretty high, 106 AHI, pretty high. Should I be really scared? No, because this patient did not have a tongue-based problem. So again, preoperative preparation, you have to do all the routine tests, cardiac fitness, thyroid workup, diabetes, blood pressure workup. Apart from that, you have to know which level is the problem. If the problem is in the base tongue, then it is a difficult intubation, difficult extubation. If it is only AHI, BMI high, but no base tongue, it is an easy patient. But if it is a low AHI, low BMI patient with a big, large muscular tongue base, that's a bigger problem. This is the preoperative, most important step. Postoperative, I would like to add to your previous question, what problems can the patient have in the postoperative period? So if you have a patient with a large tongue base, and if you pack the patient's nose, as I showed in my slides, if the nose is blocked, the tongue will tend to fall back more. So even if you've done a simple septoplasty on a patient with a large tongue base, in fact, 20 years back, there was a VIP in Bombay dead after a simple septoplasty because his nose was packed and he was, he choked on himself. He was shifted to the room and he choked on himself. So this is one thing that you have to take care of things. So while having a patient with a large tongue base, be very careful that do not, block his nose. So do the nose surgery either previously or do it in a later setting, but do not block the nose of a patient. Do not give too much of opioids in the postoperative period. The patient is going to be in pain for sure, but do not give opioids because that will make them drowsy. High BMI patient will definitely will take more time to come out because the anesthetic gases will dissolve in his fat and will tend to release later on. While coming out of anesthesia, these patients will go into hypertension. 200, 250 will be the systolic blood pressure. It happens very often, and that time your throat will start bleeding. So in those patients, while taking them out of anesthesia, you definitely have to give him some antihypertensives. So if you keep them on some nitroglycerin or NTG, then you have tachycardia. So give a beta blocker and NTG during coming out. These are the 5-6 things which have made my life much easier. And in short, I can actually put these points forward.
Okay, thank you. This is again to Dr. Vikas. This is from Dr. Manish Prakash from Gurgaon. Whether decision for inferior turbinate surgery is taken on CT-PNS or on the basis of OPD nasal endoscopy?
So, hi Manish, I hope you're doing well. Your question is extremely important. And this is one area which we are still working on. You need both. Why? Because you cannot see the bone of the inferior turbinate on endoscopy. You can see the bone only on a CT scan. So you know that you have to take out the bone of the inferior turbinate or not. So you need a CT. X-ray or endoscopy will not tell you that. So CT is an invaluable investigation for that. You also need to do nasal endoscopy because if the mucosa is quite allergic and boggy, that you'll not see on the CT scan. So obviously CT scan is a must and nasal endoscopy is a routine. You always do a nasal endoscopy before performing surgery. So I would say both of them are equally important.
Okay, thank you. Now I will request Dr. Dipankar Datta, Dr. Vikas Agrawal, Dr. Simap Sheikh and Dr. Devendra Rai to please go through the patient's profile sent by my friend Dr. Suvir Jain from Indore. And I will take opinion regarding this after taking a few questions. Right now, this is for Dr. Simap's sake. What is your opinion regarding dynamic MRI sleep study as a diagnostic tool before surgery? Dr. Simap?
Oh yes, it definitely has a big role. I think I was the major proponent of this many years back also. But we have to remember that when do I do a dynamic MRI? I will do it only once I've decided and the patient is motivated enough to find out the level of obstruction, and then pre-surgery. I'm not going to do it randomly in every patient that comes across, right? So the protocols that we are actually trying to tell people is don't rush into either a DICE, don't rush into either a dynamic MRI. Both are equally important. DICE gives you an endoscopic view of the entire airway, whereas a dynamic MRI will give you extrinsic compression of the airway. So depending on your patient, depending on the facilities that you have available with you, if you have got trained anesthetists who you think can do a DICE properly, then fine. Those patients not willing for DICE, those patients not fit medically to undergo a kind of a procedure, a dynamic MRI makes so much more sense, because it is also going to give you the actual measurements of the airway, antero-posterior, medial-lateral, as well as in the vertical dimension, it will show you the levels of the obstruction. So dynamic MRI and a flexible awake nasal endoscopy, nasopharyngoscopy, oblique a DICE is what is our ISSA protocol also. So remember that this is very easy to do. It's non-invasive. Once you tackle with your radiologist the first time, all you have to do is send them a letter saying evaluation of evaluation of OSA via dynamic MRI. And he will give you the entire set and list of all the things that you need to know, including airway dimensions, including the collapses at what level, and you have that in front of you documented, which is standardized, for example, in the sense there's not too much of inter-observer variability when you have the airway specifications in centimeters. I hope that helps whoever has asked that question.
Yeah. Okay, now this is for Dr. Dipankar Datta. What is the tension effect of bend on pterygomandibular raphe over years of suspension, and how would you treat it?
It's a wonderful question. Definitely.
This is from Dr. Vipin Kushwaha from Indore.
Yeah. So very honestly, there is no long-term data for like over 5 years or like that. So as per common sense and as per our experience, definitely over a period of time, these tensions might get loose, and there might be some minor bit of recurrence in the long run. But from Bart's pharyngoplasty point of view, of late we have started using non-absorbable suture, what Dr. Vikas has shown, because there is a more chance of retaining of the tension and the fibrosis effect. So ultimately the long-term effect is the tissue fibrosis, what is incorporated. We are incorporating the suture within the muscle and the aponeurotic bed, not the suture itself always. So, but if the patient gains weight over the period of time, there is a more chance of laxity. So just by doing some kind of reconstructive soft tissue upper airway surgery, the job is not over, and it is our responsibility to percolate the message to the patients. You have to maintain body weight and you have to maintain your BMI to a certain extent or below. Otherwise, invariably there is a chance of delayed failure and recurrence.
Can I add the pen?
Yeah, you can add.
So far in the world, nobody has used non-absorbable sutures. I was the first one to use it. I have used around 40 patients so far. So we really do not know what will happen over a long period of time, but they have used absorbable sutures for the last 8 years. And the theory has been that over a period of time, everything will fibrose, as Dipankar said. Now it's a very, very important eye-opener for me, that if my non-absorbable is going to stay for life, what will happen to the tension of the pterygomandibular raphe? Let's see what happens to it. Because my bet is that the weight of the tongue is also going to fall on that. the tongue is going to be supported by the soft palate. So it's a very, very important thing. I think that's a thing that we have to look into.
Doipan,
Yeah, please.
you allow me. I just want to add something to that question. Whoever has asked. So see, whoever has asked the question is obviously, a point with regards to tension over years. Now, if you're dealing with OSA surgery, please let's first try and understand that everything that we're doing is related to soft tissue and muscle. Not everything, but when we're discussing these kind of palatal issues. And whenever you achieve any fibrosis, whatever you achieve in the opening of the airway is definitely expected over time to lose that muscle tension. That is a given. Okay, we have to understand that. But the simile that I like to put across to people is that just because maybe 6 or 7 years down the line, if that tension is going to be given away, and yet you can manage to keep that patient off CPAP for 7 years with simple procedures that we're doing, then I don't think you should be thinking too much about that long-term tension. So it's like saying that if I do a stapes surgery, that patient is never going to get an SN loss and he'll never need a hearing aid again later on. That's not going to be possible. So if we are dealing with the age group in the 20s and 30s and we can keep him CPAP free till he's 55, 60, we all know that at 60, the muscle tone is going to be lost, whatever you've done. And somewhere around that time, he may need a CPAP then. So why worry? We should go ahead and do what we need to do at the present situation.
Okay, so this is for Dr. Devendra Rai. Sir, this is from Dr. Mohesh Kumar Nikam from Nasik. What is the suture for suspension bridge and what is life for suture? And can you enumerate the result of your study for suspension bridge?
We have done the barbed wire pharyngoplasties, but we have not done the bridge pharyngoplasty. We have done the pharyngoplasty, which have been, by Vicini and by Mario. So this is what we do. This is basically just to make a small sling, of course, but dependent on the pterygomandibular raphe. And we just make a lateral expansion of it, and as well as the superior pull towards the hard palate. As far as the vicryl that we are using is, after all, the barbed wire, and which has got small spicules. It's just like the facial lift one. And the life of, and these are absorber ones. What we have seen is that sometimes these sutures have a tendency to break. They also have a tendency to come out, and they can have a problem of a person having a foreign body sensation, in which case we leave them alone because they do get absorbed. So now Vikas has come up with the non-absorbable ones. I don't know what his experience is, whether they break or don't break. And if they do, then obviously they won't get absorbed like the vicryl one do. So that's a very big debate going on as to whether to use the non-absorbable one versus the absorbable ones. So,
Can I answer that,
and yeah, of course, Vikas.
Yeah, so basically your thing is absolutely valid. So I initially started with the same 2O non-absorbable. So that was giving a little more foreign body sensation. So then I turned to 3O, which is a thinner one. This one is actually not giving foreign body sensation to the patients. 3O is very well tolerated.
Has it ever broken?
Not yet, because non-absorbable ones are supposed to not get absorbed and not break. But it's only 2 years that I'm doing it, so it's quite early.
Right.
Okay, this is for Dr. Vikas Agrawal and from Dr. Samir Sethi from Delhi Center. After surgery, at what post of day one can start CPAP, and does it increase the risk of postoperative bleeding?
No, you can start it on the same day after surgery. It's not a challenge, and it should actually reduce the chances of bleeding because you're giving positive pressure so that the patient is not putting pressure on his pharynx to breathe. So this is absolutely fine. It should not increase the risk of bleeding.
Dr. Sethi, when you do a surgery, let's aim to try to keep the patient off CPAP. That's what we should try to aim for. Of course, one of those patients where you need to reduce the pressure, like Vikas said. You're not being able to do anything. We do static obstruction release to reduce the pressure of the CPAP.
Yes, Dr.
Can I-
Gupta,
can
do
I
you
add
want to
one?
add anything? Yes.
So in this context of the question regarding the CPAP in the postoperative period, there is a clear-cut guideline from the American Anesthesiologist Associations. The patients who are already on CPAP, the OSA patients who are already on CPAP, now we are offering surgery to them. We have to cover them with CPAP in the 72 hours perioperative period before and after. So 3 days prior to 3 days later, he will have under the CPAP in that window period. It is absolutely mandatory.
Okay. Does it create a chance of postoperative bleeding or anything else?
There is a chance of postoperative bleeding, particularly in from septoplasty point of view when we are doing septoplasty regarding the high positive pressure. But very honestly, you have to put it under in that question, that pressure management, because once the structural block, the fixed structural block is eliminated, CPAP pressure requirement is also going down from the preoperative period. So with a chance of moderate or minor brisk bleeding, we don't experience usually major bleeding.
Okay. So this question is from my younger brother, Dr. Rohit Jha from Jamshedpur, Jharkhand. How to manage lingual artery injury in the base of the tongue reduction surgery? This is for Dr. Devendra Rai.
I don't think we've got this experience because we don't do much of this base of tongue work. I think Vikas can answer this question far better than I can.
Dr. Vikas?
Yeah. So basically, first of all, most important is to prevent it from happening, because once you open up the lingual artery, it's a really difficult area to deal in. So we came out with intraoperative monitoring with a color Doppler. So back in 2012, when I started doing the robotic and I was going deep into the base tongue, and obviously that risk was on my mind, and we were doing surgeries without doing a tracheostomy. So obviously if I would have opened up the lingual, it would have been a great disaster. So we came out with intraoperative monitoring of the lingual artery with a color Doppler. Obviously I couldn't cover everything in my talk because of short time. Once if you have opened it up, then you do not try to do something and think that it will not open again. Then do a tracheostomy. We had one case where post-operatively on day 10th, patient had a bleed from the tonsil fossa, and the anesthetist tried to lift the tongue base and the whole thing torn up and the lingual artery bled like anything. So we had to do a tracheostomy, and we did the embolization and keep the patient on tracheostomy for 2 weeks till that whole thing was healed. So once it has opened, just do a tracheostomy, keep the thing pressed, then do embolization, and don't extubate the patient without a tracheostomy. You may just lose him. So once it is opened, then you have to treat it with respect.
Okay. This is the question from Dr. Komolendu Aldar and Dr. Punendu Vikas Rai from Kolkata Center. What are the management for the static problem OSA? This is for Dr. Simab Sheikh.
So static problems just straight away need to be removed. So when we're looking at static problems, we're basically looking at either the nasal or the nasopharyngeal part, because that's the only static areas where you can have an obstruction. So based on whether you have it at the septum level, turbinate level, or the nasopharyngeal adenoid level, obviously each one has a criteria. Like we just discussed, that if it is a turbinate, you have to first decide whether that turbinate is really causing the obstruction. Similarly, with a septum, we all know by now which is a really indicated septum causing obstruction, and we also know the criteria for the nasopharyngeal obstruction, where the adenoids or any tissue growth over there which is causing more than 50% blockage. So we have very specific, clear-cut criteria to handle static obstructions, and the static obstructions are generally just till the level of the nasopharynx. Everything beyond that, of course, tonsils, of course, you can call them as static. And we have criteria again to remove the tonsils, basically grade 3, grade 4, and grade 2 with anything else that is actually causing an obstruction to the palate. Then even the grade 2 can be definitely removed.
This question is again for Dr. Vikas Agrawal. Since it's a non-absorbable suture used for suspension bridge technique, what percentage of your patients experience foreign body sensation, and what's your advice if they have this foreign body sensation? This is from my friend Dr. C.V. Srinivas from Bangalore.
Yeah, I think it's a very good question. And as I answered earlier, when I was using the 2O, the thicker one, the foreign body sensation problem was more. And in fact, I had used 1O also in 2 of the patients, and they complained of foreign body sensation badly. So I switched on to 3O, the thinnest one. This one is definitely not giving that foreign body sensation any more than the routine surgery gives. So I am very happy with the 3O. And it's not available routinely. So I've got 10 boxes of 3O imported so that I have it in my stock.
Okay, this is for Dr. Devendra sir, and from Dr. Mahesh Nikam. Up to what BMI level we should operate patient or avoid what BMI level does it mandatory to put patient on CPAP?
What happens is that the BMI is taken as a 35 as sort of a cutoff. But even if there's a higher BMI, and let's say if you have a tonsil which are very hypertrophied, that person is not going to respond to any other treatment. So you may still go in for a surgery for something like a tonsillar hypertrophy. It may not be other things because that is a thing. Or let's say you have a person who's got a deviated nail septum along with that, you can still operate. The other thing is a person is really obese and other factors are not there, you should ask the person should go for a bariatric surgery also, because that are also known to improve the overall OSA. So it's a matter of debate. But if there is something which you can correct and correct it in a way which is not harmful to the patient, I think you should definitely go with it. But
Okay.
35 is taken as one of the reasons where you can think this way or that way.
Okay, this is for Dr. Dipankar Datta. Any sedative is given during sleep MRI, and if patient is anxious due to claustrophobia or noise generation, what to do? This is from Dr. Manish Prakash, Gurgaon.
The fundamental philosophy of sleep MRI and sleep endoscopy are both basically to induce sleep. It is not an awake MRI. So when the patient, we are proceeding for sleep MRI, actually we are in the MRI gantry, we are making some arrangements to make the patient asleep. So some kind of sedation obviously has to be given, like propofol or Dexmed, just like sleep endoscopy. In the MRI gantry, anesthesiologist, the physicians, and we as being ENT surgeons, the full setup along with the airway backup and the resuscitation setup should be there. So from sedation and sleepiness point of view, there is no difference between the sleep endoscopy and sleep MRI. We have to make the patient asleep within the gantry there.
That means short-acting drug should be used.
Short-acting drug, like propofol or Dexmed, 2 most commonly used drugs.
Okay, this is from Dr. Sanjay Gupta from Indore to Dr. Vikas Agrawal. What is the percentage of results after OSA surgery? Do you have to guide? Do you have to give guarded prognosis to the patient?
So honestly, Dr. Sanjay, I have had all kind of patients. I have had, thumping success, and I have bad failures as well. Let me tell you, last 12 years, I have faced everything. So I operated on a patient with a BMI of 100 and it came down to say 17, 18. And I have operated on a patient of BMI 30. It went up to 60 after surgery. Patient is saying, I'm doing very well. Earlier it was 30 apneas, now it is 60 hypopneas, but I'm a failure, right? So, and it has also happened to me that even the apnea numbers have increased after surgery. So I have got, see, when you try a new subject, you're bound to fail. So let me admit that I have the worst of the failures, the worst of the complications, but that helped me to get my results better now, because now I am more selective about my patients. Earlier, if the patient was willing, nahi sir, kuch kar do, surgery kar do, I used to do it. Now I do not. So your results initially are going to be mixed. Your patient selection is the key important area. Like Devendra sir said, if the patient say, if he has got a big lingual tonsil, huge lingual tonsil. I operated on a lady with a BMI of 45, BMI 45. Can you believe that? In a workshop with lingual tonsils. She is absolutely fine because it was lingual tonsil, huge lingual tonsil. Nothing could have worked. So you cannot just take a AHI BMI as a criteria and do something. You have to understand the patient completely. So obviously I have also failed. I'm still failing. I'm failing a little less than before, but I'm still failing.
Okay. This is for Dr. Simav and from Dr. Satish. After surgery, to improve tone of muscle, any specific exercise we have to advise to the patient? and kindly mention the post-op advice and follow-up protocols to follow.
Okay, so before I answer that, I'll just add on one thing to the previous question with regards to the AHI, what we mentioned. See, across the globe now, our criteria for deciding success of the surgeries is changing. And I think most of the surgical fraternity now realizes that we don't give importance just to AHI. So just as important as it is for you to select your patients preoperatively, also important for you to see the criteria in terms of quality of life improvement that you've done for that patient. That is what the success to that particular patient would be, not just based on the AHI. Okay, coming to the present question that is being asked. So in fact, people can go on and see the sleep global criteria, which is now being talked about across the world as the basic criteria for success for OSA surgeries. And I think most of us into the field agree with that. With regards to post-op surgeries, post-op exercises, palatal surgery wise, myofunctional therapy is coming up in a big way. There's no doubt about that. I am not really an expert in myofunctional therapy because we tend to pass it on to our dental colleagues or the orthodontists or the people who are dealing with that. But after palatal surgery, you can always ask them to follow up with them for myofunctional therapy. Myofunctional exercises are given to them. By and large, they are all related to exercises which help increase the tone of your pharyngeal muscles. So there are various ways. They're blowing this tube, blowing that instrument, etc., many things. But I think it would be better that you contact your dental colleague for the myofunctional exercises. And yes, definitely post-palatal surgery, the follow-ups after these exercises are at least 2 monthly. You don't expect things to improve very easily and very fast. But in your 2 monthly assessments of the patients who come to you post-op, obviously there is going to be a good amount of improvement.
Can I comment one?
Yeah. Please.
In this context. So not only in the post-op phase, not only in the post-operative phase, particularly for the simple snoring and the mild early situations of obstructive sleep apnea, actually we offer oromyofunctional therapy nowadays as a first-line kind of stepping stone treatment for these kind of patients in the preoperative phase, before jumping upon any surgery even, particularly for those group, just like simple snoring, mild OSA, they are not opting for CPAP at all. We are also not offering. They are not opting for surgery either. Not very scope of reducing weight, non-obese mild OSA. For them, even before surgery, OMFT, that is oromyofunctional therapy, to build up some muscle tone, to enhance the striated muscle tone of the cheek, palate, tongue and neck is coming up in a big way.
Okay. So now this question is for Dr. Devendra Rai sir from Dr. C. Shau from Meghalaya. When deciding to do a palatal surgery, how to determine how much of the palatal tissue is to be removed?
How much? I mean, there's only a basic line, what not to do. And the basic thing is this: in the palate, you have to respect the dimple. The dimple is a confluence of the upper top muscles of the levator palati and the tensor palati, and then the lower two, the palatoglossal and the palatopharyngeus, and where it is attached to the musculocuvuli. Once you identify the dimple, which corresponds to some kind of a arch of the anterior tonsillar pillars, you have to resect anything below. So you cannot resect above, as was shown by Dr. Vikas. When he was doing the uvulectomy also with the bridge pharyngoplasty, he respected that. So similarly, that is the extent maximum. Otherwise, you'll have phonation problem and swallowing problem and even nasal regurgitation and a very hypernasal voice. So that is the, as he had said, a Lakshman Rekha.
Okay. So now this question is for Dr. Simaf Sheikh. This is from Dr. Ilam Bharati and Dr. Rama Subramanian from Chennai. After OSA surgery, AHI reduced, but patient is symptomatic and dissatisfied with his snoring sound. What is your take on this?
So first thing is in your counseling. In your counseling, you have to first tell them that snoring is not the criteria on the basis of which we are going to decide post-operative improvement or not. Now, if the patient has actually come to you for snoring and he says, I'm only wanting to do it for snoring, then it was very, very imperative that you first assess and figure out whether it was a case of simple snoring or was it snoring with sleep apnea. If it was simple snoring and you identified the level of obstruction, which is very simple then because it's obviously going to be a flutter somewhere upstairs only, then the snoring has to go away. If it has not gone away, that means you did not assess the lower down obstructions at the pharyngeal and lower levels. And this is the reason why evaluation and patient selection becomes extremely important. Now, with this particular case where the patient is dissatisfied with his snoring, although you have done something, then it becomes important for you to go back in there and find out where is the snoring coming from now. Because what you probably had thought of it earlier, see, you also have to understand the dynamics of the airway. Now, for example, you did this patient of simple snoring thinking that, okay, simple snoring, I'm going to do a static obstruction, remove the nasal obstruction, and the patient should be fine. We all know the Bernoulli's phenomena. So you've removed the static obstruction in the nose, you've opened up the nose airway, air is going down faster down there, and now it's the lateral walls that are collapsing. So what was earlier probably not seen by you or missed by you is now what is actually causing the snoring, and then you will have to address those. Doipan, I'm just thinking out loud, but if you allow me 2 minutes, I promise you I will not take more than 2.5 minutes. I would just like to show a very brief edited video and this, because this is meant for the beginners. Maybe these are simple things which they can do when they can't really go wrong till they have really understood the intricacies of what exactly to do.
Yeah, you can.
Yeah, so if you allow me, and tech team can just please give me 2 minutes of screen sharing.
Please.
I'm going to just show this.
Oshin, please.
Not more than 2 to 3 minutes.
Yeah,
so
we are getting
this barb thing. I'll give you a very simple brief, because this is something where a beginner can't really go wrong. So, to put it very simply, if you start somewhere from here and you go on to the next suture right here in the middle of the the base of the uvula and the pterygomandibular raphe, then you take the third suture, you pull it onto the pterygomandibular raphe, bring it back down here to the palatopharyngeus, take it back again there, take it back again to the palatopharyngeus, take it back here. So what you've done here is within 3 places along the entire pterygomandibular raphe, not just at one point, you have the entire length of the pterygomandibular raphe where the palatopharyngeus is gone. And then finally, you've pulled it up all the way here. So now imagine when you pull this one, this entire thing is going to come laterally as well as anterolaterally. So imagine the space that opens up on both sides when this happens and then the thread is pulled in. So if you see this bit, you'll be able to appreciate what happens when you pull that, right? So this is the suture that we use, the barbed one. Again, it's a kind of a repeat, but what I'm trying to show a youngster starting off here is that they can't go wrong with this procedure. A basic tonsillectomy, everybody can do. Of course, let me again reiterate the fact that pre-op selection becomes very important. You cannot just do this for everybody, but this is a simple surgery which you can possibly do and can't go wrong because this is reversible. Okay, it is reversible. The sutures, if they extrude, if they cut open, I think I saw one question on the WhatsApp group. Somebody asked me what happens if the suture gets cut. So these sutures are removable. You can actually go in there and pull out the entire thing slowly. And when you see over here, now watch this point when the second part gets pulled up. See the pull and see the entire expansion of that anterolateral part. So this becomes very easy for people to manage when they are, just getting into it. And to add on to this, now again, something very simple. This anybody can do. So if you add a simple anterior palatoplasty to this procedure, now again, please understand, I'm just showing you simple ones, but the selection here becomes very important. What you've done here is you've just created a rectangular box 1 centimeter below the base of the uvula, 1 centimeter on either sides of the anterior pillars. go down up to the muscle level. You can do this with even a cautery, radio frequency, coblation, whatever. Go down to the muscle layer and then suture this in 2 layers. You take this first layer into the muscle and second mucosa onto the mucosa. Now, when you do something so simple like this onto a palate, for those who don't really understand the intricacies of expansion sphincteroplasty, relocation sphincteroplasty, suspension bridge sphincter, this takes a little time for you to get it when you get into the entire, intricacies of OSA. But this is one procedure which you generally can't go wrong with in the palate. If you've selected a palatal surgery procedure or a patient is fit for or meant for a palatal surgery, generally you cannot go wrong with these simple procedures for anybody entering into the field. I mean, this is something that, I thought maybe the beginners can really look into it. This is the standard Vicini technique what Dr. Devendra Rai mentioned. All of us across the globe have already picked it up from Dr. Vicini. I've been doing it also for a long time. But what I find is it has advantages. It has advantages of simplicity, reversibility, and the ability to remove that suture if it comes out. And it's an absorbable one, so the fibrosis later on anyway is going to get loose.
Thank you.
Thank you. Sorry for that. But
No. Thank you. But I am flooded with questions, but I want to take apologies from all the centers because it's high time, because now it is 3:40. So all the regional moderators are there. So I can only take 1 or 2 questions. This is for Dr. Vikas Agrawal from Dr. Rishi Ajay Khanna. As per what classification, how many levels can be addressed for surgery in a single sitting surgery?
Okay, so when it comes to a multi-level surgery involving a big tongue base, then as I said earlier, the nose should not be operated in the same sitting because that makes life more difficult for the patient as well as for you. If it is nose and palate only and the tongue base is not large, 90% of my patients are in that category. I do the nose and throat in one sitting. This is also the answer to the question of Dr. Subir Jain, who put a patient profile. I think that patient, depending on the data provided, requires a nose and palate surgery in one step. So generally 2 levels at a time, not base tongue and nose at the same time. This is what I would say. You can do palate and base tongue at the same sitting, leaving aside the nose, or you can do nose and palate, but only if the tongue base is not large. If the tongue base is large, you cannot do the nose and the palate also together. That's quite risky. And there was another question that what is the role of the nasopharyngeal tube? So the idea is that when you're performing surgery on a patient with a large base tongue, a nasopharyngeal tube goes a long way in safe, extubation, because the patient can breathe through the nose and his tongue would not go behind and touch. So that's the most important thing to take care.
Okay. So this is for Dr. Devendra Rai, sir. This is from Dr. Soumitra Kumar from Kolkata. Does leaving behind the lower pole of the tonsil lead to postoperative bleeding? And what is the lowest age of adenoidectomy in children in view of OSA? This is from Dr. Venkatesh BK.
The lower pole, if you leave it, frankly, the chance of bleeding is not too high because you're not really got into it. The only thing is that you must cauterize that properly. All that you can have is, if you leave the lower pole, there is a tendency of the tonsillar tissue to hypertrophy back again. And that not only looks ugly, but it also may contribute to the persistence of a sleep apnea, because the lower pole of the tonsil at times is very important because it can medially rotate, despite the fact the other tonsil may be totally out, but it has a tendency to medially rotate and actually give rise to a persistence of sleep apnea or a snoring disorders. As far as the adenoids are concerned, for OSS, basically it's for obstruction, of course. The smallest child I would say I've operated is 6 months, and one of 8 months also. So we have people that we can operate as less than 1 year and with very good results.
Okay, so now I am taking the last question. This is for Dr. Dipankar Datta, and this is from Dr. C.V. Srinivas from Bangalore. How will you manage the situation with a case of only functioning lingual thyroid?
only functional, definitely we should not operate on those particular patient. We have to equate the yes, whether we are dealing with OSA, then we have to go for conservative management, not surgical management of OSA.
Okay, so still I am having lots of questions, but I think we should stop here from the central part of the program. I like to thank Dr. Vikas Agrawal, Dr. Devendra Rai sir, Dr. Simab Sheikh and Dr. Dipankar Datta to be present here for this third session of Surginar. Most likely within 2 to 3 months, we will have the fourth session of Surginar with other topics. And now I will like to invite Harshad and Dr. Ashin for CIPLA to give their views and vote of thanks. And now onwards, all the regional moderators can continue in their centers. And one final words from each and every faculty. Dr. Vikas?
So the final word from my side, especially for the beginners, is that sleep apnea and snoring is the future of ENT. See, cholesteatomas are going less and less. Sinus and snoring is the future. This is what I believe. So please learn the basics of obstructive sleep apnea and snoring. And surgery is the management. CPAP is not the way forward. So it will take you some time because it's a multidisciplinary approach for a multifactorial problem. So there's no quick fix. You have to give your time to learn it. So, but learn this. This is the future.
Dr. Devendra Rai sir?
I'll first of all definitely echo what Dr. Vikas is saying. But having said that, I would rather say that like in ENT, we have got so many subsets coming in. Sleep apnea syndrome is also with us. But I feel that most of us are not devoting full time to sleep apnea, as I'm not, frankly. I am devote more time to nasal surgeries. Now, we should have more people who devote full time to sleep apnea instead of going for other surgeries. Like the ear surgery a person can do without. But in this field, one has to be more dedicated. One must have a PhD with themselves and the teamwork with a dentist and with a maxillofacial surgeon and a dietitian. So a teamwork and a person should be more focused. I think the time has come to have rather very focused ENT surgeons for sleep apnea.
Thank you, sir. Dr. Dipankar Datta?
I echo what has been said by Vikas and Dr. Devendra Rai sir. To add on that, sleep apnea is basically a multidisciplinary team approach, and my take is just like tumor board. Sleep apnea to be dealt like a sleep board, and being an ENT surgeon, we have to know when not to operate and take our chest physician's opinion, and it is expected and to train our chest physician and pulmonologist colleague when not to give CPAP and send those patients to us, and to percolate this patient to our youngsters, upcoming generations, because there is some kind of, I would say, some mental reservation and thought block among still gray areas among them. Maybe it is not that much of a subject to delve into it, not that much of guaranteed result, not actually that. It is a plenty of unanswered areas are still there, huge lot of research scope is there. So it is actually a subject of future, and I would say to invite our new generation to come into this discipline. It is a fancy subject, fascinating, wonderful, and to I would take your this opportunity and take your permission, your permission and CIPLA head office permission to invite you all during our forthcoming Indian Association of Surgeons for Sleep Apnea IASSECON 8th National Conference and our Calcutta Sleep Course 2nd edition during 16th, 17th and 18th. Our theme of this year's course is OSA practice from theory to practice like a classroom tutorial. So just come down Vishwabangla Convention Center 16th, 17th, 18th December along with live surgical workshop with major some international doyens like Professor Danny Eckert, Marina Carrasco-Latas and Ahmed Yasin Bhagat from Australia, Spain and Egypt. Please welcome all and learn this subject. All of us will be there.
Okay. Dr. Simab, final words from your side.
all of us in this field will obviously agree and partly say the same things, but the experience that I've had in the past 20 or 17 years of trying to propagate this, see, we really need to understand that somewhere earlier, we were not able to convince our own fraternity, neither the other fraternities, that we could deliver good results with OSA surgery. That's where the skepticism has been faced by a lot of us who have been, starting off this work and doing it. So now is the time that people take this in a very scientific approach. There is a lot of scope. The epidemiology, or rather the number of people available to us, is like the CI branch. There is a huge potential out there, but the potential will be there provided we are able to give results which are also evidence-based. And at the same time, we need to not get too knife happy about everything that we get. So, a lot of people's questions are always directed towards surgery. There is a lot of pre-operative planning and pre-operative thinking that goes into this. And that's where you need to pick up all the nuances. Once you understand that, and you need to propagate it to your other medical colleagues, not just the ENT people, because that's where most of our work was going away from. Like what even Vikas said, it's an obstruction, it's obstructive sleep apnea. If you don't remove the obstruction, it's not going away. But why are those patients not coming to us? Because our co-colleagues do not think that we were probably good enough to give and deliver results. So now the onus lies on all of us. We are proving it, we are showing it, we are encouraging the youngsters to come into this field, because we need a lot of people to come in there. It's a good field. It has its plus points. It has its minus points. You have to get into the understanding. And every one of us will underline and tell you, patient selection, patient selection, patient selection. Each one of us will say this and underline this 3-4 times. And that's the only message that we would like to still continue to give out. Thank you very much, Doipan. Thank you very much, Sipla, the entire team. Vikas, wonderful talk as always. And lovely to be there with Devender and Dipankar. Looking forward to that 16-17 December in Kolkata, because it is going to be a big one. Thank you, everyone.
Thanks, everyone. I will like to thank all the regional moderators from the 50 centers. Now over to Dr. Ashin and Harshad.
I think it's a sincere thanks from the team of Sipla to all of you, especially Dr. Vikas Agrawal, for one more stupendous session on sleep apnea. I think we could have more from you, but because of the limited time, we couldn't have it. Apart from that, I would like to thank Dr. Vaipan Mukherjee. He's the key anchor, pulling all this thing together and getting this program done. Dr. Devinder Rai, Dr. Dipankar Datta, Dr. Simab Sheikh, and Dr. All the regional moderators at 50 centers for being there and asking questions. I think that's it from my side, but I think I would request all of you to look out this space for some more new interesting topics which we are going to come up for our younger ENT surgeon. Thank you.
Thank you.
Yeah, once again, sir, on behalf of Sipla Respiratory Team 4, we would like to give vote of thanks to all the delegates who have joined to across 49 centers in India. And as of now, we have confirmed 800 plus delegates across India. And we would like to thank our eminent speaker, Dr. Vikas Agrawal, for taking such wonderful session on the surgical aspect of sleep apnea. And our panelists, Dr. Simab Sheikh, Dr. Dipankar Datta, and Dr. Devinder Ray, for sharing their experiences and answered the questions of delegates. So once again, thank you everybody for making this event very full, full of, sharing the experiences related to the surgical aspect of sleep apnea. Thank you.